All right, good morning, everyone. We'll go ahead and get started. My name is Glenn Peterson. I'm one of the nurse practitioners here at the University of Colorado. Thanks, everybody, for coming to the 2025 Blood Cancer Boot Camp here at the University of Colorado Anschutz Medical Campus. We appreciate everybody being here. Thank you so much to our organizers for putting this together. It's taken a lot of work to put together this conference and really appreciate everybody. Also, thank you to our speakers for being here. We'll introduce all of the speakers as we go along, but really appreciate all your hard work to prepare for this boot camp. And then also our exhibitors, thank you very much for your support and for being here. And please, everybody, visit our exhibitors in between talks. This year is, I think, a little bit different format from prior blood cancer boot camps. We're partnering with some of our specialty services to really, I think, kind of represent all of the work and I think dedication and really a multidisciplinary approach to taking care of patients with blood cancer. So I hope that comes through in our talks today. And again, welcome. We'll get started with our first talk, and we'll have Alex get us started with some introductions.
All right, thanks, Glenn. So I have the privilege and honor of introducing two people who are institutions all to themselves here at the University of Colorado, and that's Glenn Peterson and Harry Brackett. So Glenn Peterson is a nurse practitioner and associate professor at the University of Colorado School of Medicine. He practices in the Division of Hematology, Anschutz Medical Campus Cell Therapy Center. Glenn obtained his BSN at South Dakota State University and his acute care nurse practitioner degree at Rush University in Chicago, and his doctor of nursing practice here at the University of Colorado. Glenn is quality director for the Division of Hematology and director of APP Education and Quality for our division as well, and he has served in numerous other roles throughout his career at the University of Colorado. Harry Brackett is an assistant professor at the University of Colorado School of Medicine and an advanced practice provider and clinical nurse specialist practicing in palliative care at Anschutz Medical Campus. Harry also holds the advanced certification in hospice and palliative care nursing. She has 35 years of nursing experience and has worked in the areas of inpatient and outpatient oncology and blood disorders in the capacity of staff nurse, nurse coordinator, case manager, clinical nurse educator, and clinical nurse specialist. Harry has also served as the lead APP for the UCH Inpatient Palliative Care Consult Service since its origination in 2005. So we have some really good speakers, and they're going to be discussing acute myeloid leukemia, and we'll have a Q&A session after. So if you're online, make sure you're entering your questions into the chat, and we'll take those at the end. Thank you.
All right, thanks a lot, Alex. Really appreciate it. How's the sound? I know there was an echo. Does it sound okay now, though? Okay, great. So again, thanks for being here for our talk on acute myeloid leukemia and palliative care. And it's really an honor for me to be able to be up here speaking with Harry Brackett. I don't know how many people know Harry, but she's been here for so long and has made such a tremendous impact on literally thousands of patients through her work in palliative care and especially our oncology population. So really appreciate it. I'm very happy to be up here with you. All right, let's see. All right, so our learning objective. So we're going to talk about the clinical presentation of newly diagnosed AML, some of the complications associated with AML, treatment options for AML, and then also the importance of palliative care upon diagnosis for patients with acute myeloid leukemia and then beyond throughout their treatment course. We have no disclosures. So acute myeloid leukemia is the most common acute leukemia in adults. It's a disease of the elderly. The majority of patients are diagnosed over the age of 65 and about a third of patients over the age of 75. It's a very heterogeneous disease with heterogeneous presentations. No AML presents exactly the same. Generally, AML has a poor prognosis and it's very difficult treatments for these patients, difficult course. These patients have universally poor outcomes, especially in the elderly population, but treatment options are expanding, which we'll talk more about as we go along in this talk. So though in 2025, there are about 22,000 cases of acute myeloid leukemia. This is about 1% of all new diagnoses of cancer, but it's about 2% of all cancer deaths. The 5-year relative survival is only 33%. And again, this slide just depicts the fact that these patients are elderly patients, older patients, which will, I think, kind of weigh in on some of the discussions we'll have about acute myeloid leukemia and the treatments that we provide them these days. So again, we know that not all AMLs are created equal. Again, very heterogeneous disease. These patients present in all kinds of different clinical varieties. They're not equal in regard to their risk classification. Of course, they present at different ages. The majority are elderly. However, we do see young patients present with acute myeloid leukemia also. Again, the presentation is variable. Patients sometimes come in with a very low white blood cell count, very stable, and then others will come in with a very high white blood cell count and unstable with a variety of complications that we need to work with and deal with. The risk classification. So this is the ELN, European Leukemia Network risk classification for non-APL AMLs. APL is a much different type of acute myeloid leukemia, which we're not going to spend time talking about today. And this is the risk classification for patients treated with intensive induction chemotherapy. So we'll talk later in this discussion of how many of the patients, again, elderly patients, treated with less intense, so non-intense chemotherapy induction regimens, how the prognosis and some of these risk factors really are somewhat variable. So we know that based on the risk, of course, patients have different outcomes. So patients with favorable risk disease do much better than those with unfavorable risk disease. But you can see, at least in this data, which is a bit old, that still, the survival, even in the most favorable risk groups outside of APL, is still only 55% at 5 years. So there's still a broad group of patients that we have a lot of progress to make. And then on the right side of the screen, this is really showing some of the molecular abnormalities that we see and how that relates to their risk and then outcomes. So this is a case study on a newly diagnosed acute myeloid leukemia. This is a real world case. So this patient, RJ, is a 70-year-old male with a lot of comorbidities who presents to his primary care doctor with 2 weeks of low-grade fever, fatigue, cough, and unusual bruising. On exam at the PCP's office, you can see the vital signs are not normal. The patient's ill appearing, he's pale. He's got signs of low platelets with ecchymosis and petechiae, and you can see the labs are very abnormal with a white count of over 100,000, low hemoglobin, low platelets, and about 80% blasts. In addition, the patient's metabolic panel is quite concerning with an elevation in some of his electrolytes, some impending renal insufficiency, and then also evidence of DIC. You can also see on the x-ray that his right lung is infiltrated with a pneumonia. The patient was sent to the emergency department of the local academic medical center. And then on presentation, the patient looked very unwell with hemodynamic instability and increasing fever and now a lactate. The inpatient blood cancer team was consulted immediately to evaluate the patient. And then anti-sepsis interventions were implemented, and the patient was sent to the intensive care unit. Repeat labs in the ICU continued to worsen. The patient has a progressive white blood cell count, progressive DIC, and evidence of tumor lysis syndrome, which we'll talk about more here in a bit. The blood cancer team, again, was involved and sent stat peripheral blood flow cytometry and FISH testing. So it was negative for the characteristic genetic abnormality of acute promyelocytic leukemia. But flow was consistent with acute myeloid leukemia, and a bone marrow biopsy was done, which showed a complex karyotype, which again falls into that poor risk category of patients. And again, negative for APL, but positive for FLT3 ITD, which again also portrays a more poor prognosis for this patient. So a difficult case, difficult disease, and a difficult diagnosis. So the patient was initiated on hydroxyurea therapy to try to bring the white blood cells down, completed leukapheresis twice to reduce the white blood cells, and they got the white count down to 30 for this patient. Patient did stabilize and improved with the anti-sepsis interventions and bringing the white blood cell count down. In discussions with the oncology team, with the hematologist, the patient was deemed unfit for intensive induction chemotherapy due to significant comorbidities. And then the patient and family preferred not to proceed with any type of intense chemotherapy. So the white blood cell count dropped to about 25,000, and the patient was started on azacitidine plus venetoclax. And then given the really kind of the entirety of this difficult situation and the need for additional support, the palliative care team was consulted to discuss goals of care and how they could help this patient.
So enter palliative care. So I'm going to talk about what palliative care is and what it is not. So pre-palliative care consultation, we're going to talk a little bit about getting on the same page and the communication process and what the palliative care upfront role is. And it's really about good symptom management, learning about value-based goals of care. What is this patient's story? And advanced care planning. So let's define palliative care for really what it is. So when you think about palliative care, think about it, and this is what we describe to the family. We are a specialized medical team. There are 3 buckets that we do. Whoops, it's going too fast. Okay. First of all, we help people who have serious illness like yours with symptoms, so you feel better and you have better quality of life. We help with communication because we know you're seeing a bunch of people. And we try to put all the information together so you can get one really good, complete overview of what's going on. And the big thing we do, and this is my favorite, we learn about you as a person because we know you're much more than just your new leukemia. In fact, Hippocrates said that it is more important to know what sort of person has a disease than to know what sort of disease a person has. So it's really important because when we get consulted for goals of care, there's this dichotomy. A lot of times people think, oh, we want to know how much they want and how much they don't want. Do they want chemo? Do they want radiation? Do they want to go through this? All palliative care people in their minds change that. And we changed it to, you guys really want to know what this person's values are, what their priorities are, and what is important to them. And then we match those values to what's available. So we learn about the person behind the disease. This allows time for the patient's story. And the reason we do this, it brings valuable information to the forefront. It helps the patient and family with life review. It helps them realize what is important now. It often helps them discover the best part of themselves and the best steps for themselves. For us, it helps with rapid rapport and trust, because often we only have like an hour and a half with them for that first consult. And I know I say only, but in the scheme of things, RJ's probably been in the hospital now for a week or so. So now this is our 1 hour to try to get rapport quickly. Oh, this is going. Okay. And of course, we help with complex and total pain syndromes. Now, one of the slides I accidentally skipped over because I thought it was coming up later was when we first get a palliative care consult, what are things that we do? I'm just going to go back to that slide. Sorry, guys. We want to get on the same page with who consulted us. There's a very specific communication process. So when we get consulted, it goes through Epic. Our nurse care manager calls the consultant, learns a little bit about them, and assigns the patient. So say I'm getting the patient with my attending, and Glenn is the APP. So I'm going to call Glenn and I'm going to get the skinny on the patient. I've already read the chart and I've looked at the labs and I'm thinking to myself, oh my God. But I'm asking Glenn, what's going to be offered? What can be offered? What are the risks? What are the benefits? And what are the burdens of what's going to be offered? Risks are side effects. Burdens are the pain in the butt things, like how long are they going to stay in the hospital? Who's going to take them back and forth to clinic? And of course, benefits is how much time is this going to give them, both in terms of prognosis and quality time. So I'm going to ask all this of Glenn before we go into the meeting. So we're on the same page. And I am pretty educated now on RJ and his treatment. And then we're going to make sure that the important people are in the meeting, like the person's medical power of attorney or somebody that is able to listen and speak for them. So now I'm going to go forward. Sorry about that, you guys. So my team goes to meet RJ. And you heard who RJ was from a medical perspective. Here he is through a personal perspective. He's a 70-year-old retired high school teacher. He's been previously independent. Remember that, a couple weeks ago, he was probably still teaching. He was probably still playing golf. And then all of a sudden, to him, he's just getting weaker and weaker, and he lands in the hospital. He lives with his wife of 45 years, Mary Ann, and they met in Greeley. They were both undergrads for education. They have a daughter who's an adult daughter, and she is a single mom to a 12-year-old. He really, really enjoys the outdoors. He enjoys camping. He enjoys working with the Boy Scouts. He teaches his grandson about the outdoors, and he likes reading historical fiction. And we've learned that, as Glenn said, he has a lot of fatigue, weakness, and bone pain. So his value-based goals of care, these are the things that are most important to him. Being around his wife and family, being able to be as active as he can, not being a burden to anyone. He wants to stretch out his time. He's not ready to die. He wants to get his affairs in order to make sure that his family's okay and that he's not a burden. So that's what we learned about him. And then we spent time in the consult transitioning to medical. Glenn will be RJ. He was going to wear a wig, but he forgot it.
I'm close to fitting into this age category.
Yeah, you need a walker? Okay. All right. So, Ron, thank you so much for telling us about yourself. Now, let's keep in mind some of the things that you told us are important to you as we transition to the medical piece. Is it okay if we do that now?
Sounds good.
Okay. Just so we're on the same page, what have the providers been telling you?
Well, they've told me that I have a really bad leukemia and that my white cells are crowding everything out. All the other good cells are getting crowded out.
Yeah.
And I'm probably too old and too weak for the strong chemotherapy, but I don't really want it anyway.
Okay. Can you tell me more about that?
Yeah, I had an uncle who had cancer. He had strong chemotherapy and it made him 10 times worse. I don't want to go through that too, but I also don't want to just give up and die either. Mm-hmm. They told me there's this light chemo I can have and it may do the trick for a while. So they're going to start it. They also said I might need a stem cell transplant.
Well, Ron, it really sounds like you have a good handle as to what's going on. When you say it may do a trick for a while, what do you mean by that?
Well, they said this light chemo may even put me in remission. I don't know how long though, and I'd still likely need a transplant, which I know is hard. Do you know anything about these type of treatments?
So now palliative care is going to transition to giving some serious information. And remember, we spent time with Glenn prior, so we kind of know a lot about what Glenn's thinking, about what the team is thinking. And so we feel pretty confident in telling information. Of course, the primary team is always welcome to join our consults, so we do it together and we collaborate together. Sometimes that doesn't work timing wise because you guys are so extremely busy. But the way we do it, and it doesn't have to be us, it can be you all, but this is a really good way to do it. First of all, you always seek permission. You know, is it okay if we talk about something that might be pretty hard? Notice I gave a warning shot. So for anything serious, you have to seek permission and give a warning shot. You state the news pretty directly without a modifier. You don't say at this time or right now. You just kind of say it and then you pause and keep silent and then you empathize. I know that a lot of people with nursing background know the nurse mnemonic. And that stands for, N is for naming the emotion. You know, it sounds like this has been pretty hard on you. This is really devastating news. Expressing understanding. I can only imagine how tough this is. You never say, I understand, because do you guys understand? There is no way you understand what this person's going through. You show respect. You know, I really admire, you know, your dedication to your family, your faith, your commitment, your resiliency. You provide support. You know, we want you to know that we are going to help you with a plan. And then you explore. So if you don't know what to say, you say this, tell me more. So back with RJ, you know, Ron, would it be helpful if we talked plainly?
Yeah, that's really the only way I want to hear it.
You know, this is going to be hard to hear. You know, it sounds like with this regimen, the team is hopeful that you'll get into remission, but, you know, they're unsure how long. The time might be shorter than we like. With a stem cell transplant, however, that could potentially cure you, but that's going to be a really tough journey. It's going to be some uncertainty.
Yeah.
You know, this is really tough. I wish I had better news for you. You know, the medical teams are going to be here for you, and your family's going to be here for you, and we'll get you through this.
That is tough news. I knew deep down that something was wrong. I'm glad I have my family to get through this with me, though.
Yeah, me too. You know, I really admire your strength and how brave you're being.
Well, now what?
Well, now we support you through this. And two things that our team can do. You mentioned you had pain, and you mentioned you wanted to get your affairs in order, and we can help you do these things. Is this a good time to start some of that?
I think so.
Okay, let's do that. So now palliative care is going to go into some complex pain assessment. And remember, palliative care, we are trained in pain and symptom management training, especially with malignant pain. And this is based on our individual clinical and emotional assessments, because pain is not only physical, it's also emotional. And it's also based on equal analgesic dosing. Now, we have assessed that RJ's pain, he has bilateral pain to his hips. It's intermittent. It increases with walking. It's 5 out of 10. It's achy. So this is what he's been getting. Oxy 5 to 10 Q4 PRN and hydromorphone 0.2 to 0.4 Q2 PRN. Remember these doses because you're going to need to know this for math. So in 24 hours, he got Oxy 60 and he got hydromorphone 3.2. So the best way to get RJ out of pain quickly is with a PCA. And so we are going to talk to RJ about a PCA and how that's being used. And we're going to talk to the primary team that this is our recommendation. Now, you can figure out any kind of equal analgesic conversion by doing this algebra. Current dose over X, X is your new dose, equals current ratio over new ratio. Now, if you Google on your phone, UCH equal analgesic pain, and go to an image, you get the ratios. So here's my math. 60 over X equals 20 over 1.5. So I'm converting to hydromorphone. And I do my algebra, my cross multiply. It turns out then that 2.7 is what I'm getting. Now, the original math was 4.5. Because we're really conservative and we know you guys are conservative, we're going to cut it by 40%. Because I don't know how he's really going to do on a PCA. And like I said, I'm being conservative. So that's why I multiplied it by 0.6, 40% reduction. So this guy got 2.7 of hydromorphone from the oxy. Plus we know he got 3.2, remember, from pushes. So I add those two together. That's how I get 5.9. I divide that by 24, and that's 0.2 an hour. The demand is always half. So that's 0.1. It's always 10-minute lockout because peak effect is 10 minutes, and then it goes down. And the RN bolus for rescue is always double the demand because the patient's pushing it, and he's not getting enough. So we want the RN to at least be able to give 100% of that back. So we see how he does in the next, day or two. We come back and say now he's feeling pretty good. We got his pain under control. And the primary team really doesn't want him on a PCA, and neither do we. So we're going to convert him to a long-acting OxyContin. Same type of ratio, current over new equals current over new. And I'm getting that from my equal analgesic dosing. I do my math. It's X equals 77. I decrease again because I'm conservative for incomplete cross tolerance. And then I'm getting 46 of oxy in a day from his PCA, or OxyContin 23 BID. Well, oxy doesn't come that way. So it comes 20 BID, and so that's what we give him. Breakthrough dosing is 10 to 20%. So the breakthrough is going to be 5 to 10. I'm going to do something different. I'm going to do Q2 hours because peak effect for an opioid is really 60 to 90 minutes. There's no reason to wait 4 hours if somebody is having a lot of pain. No reason. So it peaks and it goes down. And if people are really conservative, you can do Q4 hours, but know that it's safe to do Q2. And when he's ready to go home, he can follow up in palliative care clinic. The other thing he wanted to do is some advanced care planning. And advanced care planning, is really trying to plan documents that allows his voice to be heard, even if he can't speak for himself. So at UCH, the first thing that we do, patient gets admitted, the nurse asks, RJ, if you get sick or fuzzy and you can't make decisions for yourself, who's the person that makes decisions for you? And then he might say a name. And then that becomes orally appointed, which really in real life, in legal life, that doesn't mean anything. We have to make him, encourage him to fill out a medical power of attorney. And then that becomes the person that makes decisions for him when he can't. So next steps, what we're going to do for subsequent consults is keep asking, how are you doing? Checking in on pain, doing more advanced care planning. How much is too much? Is this still in line with your value-based goals of care? Really advocate that he's asking the risks, the benefits, and the burdens of everything that comes his way.
Great. Thank you, Harry. as I was listening to Harry talk about things, it's just like, if you think about the case that I presented, and then, which was purely laser focused on the medical side of things, the diagnosis of acute myeloid leukemia, and then listening to Harry talk about, well, it's the situation is far, there's so much more to it than just the disease. There's this person that, you know, has lived their life a certain way, has prepared for all the things in life, who has tried to do the right things for their family, and now things are completely turned upside down. But I think it's a nice perspective to remember, because again, we're always, as clinical providers for patients with acute myeloid leukemia, we're so focused on that disease, getting rid of it, and trying to cure that patient. And that's it a lot of times. And so I think listening to this perspective is so important in the management of these patients. I am going to continue on the clinical management of acute myeloid leukemia now, but I think never forgetting the importance of thinking about the person behind, that disease that we see right in front of our face. So AML management. So how will your patient present? I think we always put these patients in three buckets, really, in how we manage them. So maintaining clinical stability is the first bucket, the most important bucket in our mind when we have a patient newly diagnosed with acute myeloid leukemia, and then getting the diagnosis and moving on to treatment as soon as possible. And again, we like to see this trend, this progression of care occur very quickly for these patients. So in regard to clinical stability, we think of four big conditions that many acute myeloid leukemia patients encounter. The first is hyperleukocytosis leading to leukostasis, tumor lysis syndrome, DIC, and sepsis. And we'll talk about those last two on the next slide. In regard to hyperleukocytosis and leukostasis, so this is a condition, a hyperviscosity condition, that may result in tissue ischemia, infarcts, and thromboembolic events. It causes mental status changes or stroke-like symptoms, respiratory insufficiency, priapism, extremity compartment syndrome. And really the fix to this, or the prevention of progression of this condition, is to cytoreduce these patients with a couple of different strategies. One, a pill called hydroxyurea in escalating doses, and then leukapheresis. And there's I think not a lot of great data behind leukapheresis as far as long-term outcomes and overall survival. However, acutely can be very effective in patients whose white blood cell count is not dropping on hydroxyurea. And we do this prior to the initiation of therapy, and we think that it reduces complications of leukostasis and treatment. And then we get going with treatment for acute myeloid leukemia just as soon as possible. In regard to tumor lysis syndrome, so this is a life-threatening condition that occurs after cellular destruction of rapidly growing tumors, and then the subsequent release of the intracellular components of tumor cells, such as potassium, phosphorus, uric acid, and then a subsequent drop in the calcium, and potentially all of this leading to acute renal failure. Clinical tumor lysis may result in rapidly progressing renal failure, seizure, and cardiac dysrhythmia leading to death. Some of the treatments and the management strategies for tumor lysis syndrome include allopurinol and respiricase to lower the uric acid, IV fluids, and then, of course, we monitor these patients very closely with labs every 4 to 6 to every 8 hours. Monitor patients on telemetry, monitor EKGs, manage their electrolytes. We can't allow potassium to go high, phosphorus to go high, and uric acid, and we have to monitor and hopefully prevent acute renal failure. However, some patients will require renal replacement therapy, such as CVVH, in the midst of severe tumor lysis to prevent morbidity and mortality. DIC is an oncologic emergency that develops secondary to an underlying pathologic condition. It never just happens on its own. So it's due to some underlying cause. And in almost all cases in blood cancers, it's due to their malignancy or infection. It's a coagulation disorder characterized by widespread intravascular thrombosis causing tissue ischemia and organ dysfunction. There's also a consumptive depletion of coagulant factors and platelets, which contributes to hemorrhage. So these patients clot and then bleed. So these patients require frequent lab monitoring, kind of like tumor lysis syndrome, every 6 hours or so to monitor their coagulation levels. And then we replete blood products, which is really kind of the only management strategy outside of just treating the disease that is effective. So giving platelets, FFP, cryoprecipitate, red blood cells as needed. Sepsis. So we know sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock is a subset of sepsis with circulatory and cellular metabolic dysfunction associated with a higher risk of mortality. So antisepsis interventions for these patients are, of course, volume, ID workup for all these patients very quickly, and then start antibiotics as soon as possible. We love to see antibiotics infusing within an hour of the first sign of infection or sepsis, which may be just a fever alone. And then some of these patients require the ICU for severe sepsis and septic shock management. Okay, moving on to getting the diagnosis. Again, a very part of the full picture of the management of acute myeloid leukemia. And one of the things we always talk a lot about as clinical providers, getting to the point where we're ordering a lot of tests and so on to diagnose a patient or to intervene on a patient situation, it requires the first thing is doing a good exam on patients. The number one most important thing that we do is listen to patients, talk to patients, and then examine them. And then we order tests based on our examination. So some of the tests we order, right off the bat, we order stat blood studies to look at flow cytometry to really understand what type of leukemia this is. Is it a lymphoid malignancy or a myeloid malignancy? And of course, in the case of AML, this is a myeloid malignancy, which can be determined on flow cytometry. And then we send FISH studies to make sure they don't have acute promyelocytic leukemia, because the treatment course is completely different for that disease. And then we get a bone marrow biopsy and send all the tests, morphology, flow cytometry, cytogenetics, FISH, and molecular studies, and then whatever clinical trial related testing we need to do. This is really a depiction of some of the molecular abnormalities we see in acute myeloid leukemia. So then moving on, once we have the diagnosis, and again, so clinical stability, that first couple of days, make sure the patient stays stable, and then quickly get the diagnosis and get them started with treatment. Usually at our facility, we have patients on treatment within 72 hours of them walking through the door or being brought in some way, shape, or form. So then treatment. So treatment considerations in acute myeloid leukemia. What are the options these days? And there are expanding options for patients. So really kind of the broad course of treatment looks similar to this. So we induce patients, potentially re-induce patients if they don't fully respond or don't respond to the induction treatment. And the options for induction and reinduction include intense chemotherapy or less intense chemotherapy, plus minus targeted therapies for whatever molecular abnormality they may have. And then we consolidate patients with either more chemotherapy or more or less intense treatment or transplant, stem cell transplant. And then we maintain these patients on some form of treatment to keep them in remission. And that may be continued chemotherapy or less intense treatment or maintenance even after a stem cell transplant. So intense versus less intense is a pretty big topic of discussion over the last few years, when we actually have developed some other treatments besides intense treatment. So treatment is really based on the combination of these factors. So disease characteristics are very important. So what risk classification does the patient fall into? And this is, again, based on their cytogenetics and their molecular studies. Do they have an antecedent heme malignancy, some other hematologic disorder that led to the development of acute myeloid leukemia? Or is this a therapy-related AML? These are some considerations for these patients at the time of diagnosis. And then at least as important are what are the patient characteristics? What is the patient's performance status, comorbidities, physiologic age? And as we know, we have a bit of, in a kind of have a luxury of having very fit patients late into their life here in Colorado. I mean, we have 70s, 80-year-old patients come in that are quite fit, doing all kinds of things that, 60-year-olds or 50-year-olds are doing on a daily basis. So things are a little bit different here, and we have some additional options for patients in their older age. And then also, what is their social situation? What is their family situation? Do they have a caregiver? Do they have somebody that can bring them to, appointments and support them during this treatment, which is very important. And it also becomes especially important if we're offering a patient a stem cell transplant. And then what is the patient's preference? I think in hearing more from Harry on goals of care for patients with acute myeloid leukemia, it's very important to understand really what does the patient, in a very informed way, what does the patient want? What do they and their family think they should, and can kind of go through? So lower intensity therapies. I'm going to spend the majority of the rest of this time talking about lower intensity therapies, because I think this is really the most important category of treatment for patients. Because remember, these patients, the majority of patients are diagnosed over the age of 65, many over the age of 75, and they're not candidates for highly intensive therapy. It's just not an option for them. So thankfully, we do have some options for patients that are intensive induction ineligible, or they just don't want it. And so these are the NCCN guidelines looking at the lower intensity therapy options for patients. And really, regardless of mutation status, azacitidine and venetoclax tend to be our go-to regimen. There is approval for ivosidenib and azacitidine combinations in patients who are IDH positive. But again, as far as lower intensity regimens go, our typical treatment is azacitidine and venetoclax. So I'm going to talk a little bit about venetoclax-based treatments. Venetoclax is a BCL2 inhibitor. BCL2 is an anti-apoptotic protein that is overexpressed on the leukemia stem cell. And we know that inhibition of BCL2 induces apoptosis of leukemic blasts. Venetoclax has an FDA approval for the use in combination with a hypomethylator low-dose cytarabine for the treatment of newly diagnosed AML patients who are over the age of, who are 75 or older, or have comorbidities that preclude the use of intensive induction chemotherapy. The NCCN recommendation is for patients over the age of 18 who are not candidates for intensive induction chemotherapy with newly diagnosed AML, regardless of mutation status. And, I think that's an important distinction that, even if a patient is less than 75 years old or even younger, many of them are just not fit. They're in a tough state with their new diagnosis, lots of comorbidities, complications related to this disease, which can be very aggressive. And so this regimen is an option for those patients. In regard to hypomethylation, so our hypomethylators, azacitidine and decitabine, cause hypomethylation of DNA and direct cytotoxicity to abnormal hematopoietic cells in the bone marrow and may induce cellular differentiation or apoptosis. So a little bit more on azacitidine venetoclax. This is the results of the VLAA trial that shows a 5.1 month difference in overall survival between venetoclax and azacitidine versus azacitidine alone. And this is long-term follow-up data of VLAA showing that continued separation in these two lines over time, and especially in patients with IDH mutations. Venetoclax resistance, though, is an issue, and something that has been, I think, discussed more because, we have patients that respond dramatically well to venetoclax-based regimens and can live for many years. I mean, and we treat patients, we have a 95-year-old patient right now who's been on venetoclax for the last couple of years and doing great with no sign of disease. And but there are, so we have these super responders that just respond so well to venetoclax, and there are some favorable factors that lead to this kind of super responder category of patients, but there are patients that don't respond well or lose a response or progress on venetoclax. So there's been a lot of discussion on what are the factors in patients who receive these low intensity regimens that are typically venetoclax based that lead to resistance or failure. And then what can we do about it is the big question. Can we find something that helps these patients? So the ELN has made recommendations or guidance on risk categories for patients who receive less intense therapies, and have, again, put them into categories of risk, of favor, intermediate, and adverse. But I think one of the things to remember is that now on venetoclax-based regimens, not every patient is older. So the VIALE-A trial is older patients, right? But now we're treating patients younger with this regimen. And also a good portion of these patients go to stem cell transplant. So our approach at the University of Colorado is patients that we think are going to respond to venetoclax, we put them on venetoclax and azacitidine, get them in remission, and then get them to transplant. So in considering younger patients and transplant, Dr. Pollier here, Christine McMahon, and Dr. Lakowitz from MD Anderson have put together some recommendations on really some additional recommendations with actually in the favorable risk category of patients, we actually have improved survival in patients due to some of these additional variables. So the favorable factors in our eyes for venetoclax are NPM1, IDH1 and 2, and DDX4-1 as molecular abnormalities. These patients can fall into that category of these super responders that go on for years treated on venetoclax-based regimens. And then our intermediate factors, NRAS, FLT3, ITD, and then other mutations not favorable or adverse. Adverse factors, TP53 mutations, KRAS, PTP-N11, and then disease characteristics such as monocytic disease, especially M5, is very difficult for all types of treatment we have to offer. Doesn't matter whether you give these guys venetoclax or you give them an intensive induction regimen, they don't do well with TP53 and monocytic disease. And then we also can get some early information in patients in regard to their disease-specific characteristics. If they're CD7 or CD56 positive, these patients don't do well really with anything you give them. These are typically TP53 mutated patients also. So relapse refractory acute myeloid leukemia. Now what do we do? This is a very challenging situation to be in. And we always think of clinical trials as really the first line of treatment. So relapse refractory AMLs, we know their outcomes are very poor. And we know there's a lot of research that needs to be done to fix this problem. And so clinical trials are very important to try on these patients. We do have other targeted therapies based on the patient's molecular makeup, such as FLT3 inhibitors, IDH inhibitors, CD33, monoclonal antibodies that we can use for patients, KMT2A inhibitors, and NPM1. So these, again, are options for patients who are relapse refractory that have a specific mutation. I'll talk a little bit more, and I apologize, we don't have time to go into a lot of detail on these medications, but so we have FLT3 inhibitors. So FLT3 inhibitors induce intracellular, FLT3 mutations induce intracellular signaling pathways causing cell proliferation and anti-apoptosis. This is the most common genetic abnormality in acute myeloid leukemia and portrays a poor prognosis. Falls into the intermediate category in the ELN criteria for intense regimens, but it is a difficult molecular abnormality. We have drugs such as gilteritinib, midostaurin, and quizartinib to treat FLT3, depending on the ITD or TKD status. IDH inhibitors, so isocitrate dehydrogenase gene mutations, such as IDH1 and IDH2, prevent differentiation of AML cells. These occur in about 30% of AML patients, and IDH inhibitors promote normal differentiation of AML cells. And some examples of these are enasidenib, ivosidenib, and olutasidenib, depending on their IDH 1 or 2 status. We have menin inhibitors now, or revumenib, that is an option for patients who have MLL gene abnormalities, KMT2A rearrangements, and the 11q23 chromosome. These occur in about 5 to 10% of adult AMLs. MLL translocations form protein complexes that upregulate leukemogenic genes. Inhibiting the interaction between MLL and menin can reverse leukemiogenesis. And in addition, revumenib inhibits NPM1 also. So what about stem cell transplant? So allotransplant is a potentially curative therapy for many elderly acute myeloid leukemias into their late 70s and even early 80s. We've transplanted patients up to 81 years old here with good success. So one thing to remember is that unfit for intensive induction does not mean unfit for transplant. It's a very important distinction. And again, we take all kinds of elderly acute leukemics to transplant here. So patient selection is important, though. We want patients in remission as near as possible. Patients in MRD we will take to transplant. We know that younger patients tolerate more chemotherapy in their conditioning regimen versus older patients who do not. Comorbidities are important to consider. Donor selection is very important, and we have a lot of options for donors these days. And also, again, patient preference. Does a patient want to go through a transplant, and can their social situation handle it? One thing to remember, and we'll move into kind of the last part of this talk, and Harry will finish with some more information on palliative care, but we know that not everyone is a candidate for curative therapy with a stem cell transplant, and not everyone is cured, even though we do it. And there are post-transplant complications that are very important to consider, and you'll hear more from Katie and Tracy later on about some of those transplant complications. This is a bit of data on the question of to transplant or not to transplant. This is a small group of patients here at our center, but patients who undergo azacitidine and venetoclax, again, our approach is to get them to transplant and CR1 as soon as possible. And these are the kind of results that we can get from patients that are on azacitidine and venetoclax, and we can put into a transplant. So you can see that the data is clear that patients who receive a transplant do much better in regard to overall survival than those do not. All right.
Well, we've gotten, I think there's been so many medical and leukemia advances since since I used to do heme-onc in the 90s. So this is pretty incredible. So the crossroads, again, palliative care and AML, we always hope for the best. And the key is also planning just in case, being prepared for the worst. Throughout somebody who has leukemia, throughout their journey, we can assist with coping, goals of care, the transition, and the continuum between inpatient and outpatient. These are just 4 articles that I pulled that illustrate the new marriage between AML and palliative care. So say that somebody is having a relapse and that these amazing advances still aren't working, or that the patient and family really feel like they emotionally and physically just can't do it anymore. So we might come back into the picture just more intensively, where we review their story, review where they're at now, what's important to them now, matching what's important to what's really medically possible now, and insisting with these conversations and reviewing the paths forward, making recommendations. So more advanced care planning. At this point, we might be reviewing what their code status is. If your heart stops and your lungs stop and you die, there are 2 roads. One road is to allow you a natural death, and the other road is to attempt to resuscitate, bring your heart back, which usually means going to the ICU and putting a tube in your windpipe and connecting you to a breathing machine. And we talk about, what are the chances of you getting out of the ICU and getting off the breathing machine? And usually our recommendation is to allow a natural death at this point. And maybe not escalating to the ICU, but doing all the treatments in your room, having transfusions if that's still appropriate, having the antibiotics and antifungals if it's still appropriate and you want to go through this. And maybe the use of time-limited trials, going through something for maybe a week's time. And if things don't turn around, then we think about something else like comfort care. So I want to talk about what hospice is. At this point, it's really support for people who have an incurable illness in the last phases of life. And Medicare, Medicaid, and insurance pay for hospice in the last 6 months of life. Hospice feels that the dying process is a normal part of living and of being human. Hospice affirms life. It doesn't hasten nor postpone death. And it really is there to promote and preserve an inherent potential for growth and resolution for patient and family. Where is hospice delivered? Well, most of the hospice in our community is delivered at home. Hospice is 100% covered at home, which is an RN that comes to the house a couple times a week, CNA visits a couple times a week. Now, the caveat, it's not 24/7 care. They stay for about an hour or two. So they do need a caregiver at home. There's all durable medical equipment is covered, a hospital bed, a wheelchair, those types of things. And they get 24/7 phone emergency care. So if Marianne, who's the wife of RJ, gets scared, she can call day or night, call hospice. The nurse calls, gets her through what's going on, tells her what to do. And if still scared and unsure, they send somebody to the house day or night and weekends. Again, but you need a caregiver. There's also inpatient hospice, and that is 100% covered as well if the patient meets GI criteria. And to remind you, we do have GI in the hospital, which means uncontrolled symptoms, uncontrolled shortness of breath or pain or agitation. So usually if you go into a hospice, that length of stay is 3 to 5 days, and then they do really well at getting your symptoms under control and they send you back home. This is what Denver hospice looks like. Not too shabby. So there's double doors out to a patio. Every room has this, and you can move your bed outside. Sometimes when people don't have acute symptoms, they don't qualify for general inpatient hospice, either in the hospital or here. So then these people have to go to a nursing home. Room and board's not paid for at a nursing home. It's like $400 a day. So it's really expensive. So that's why, as providers, we need to be very clear as to what prognosis is. Because families, I guarantee you, and I have heard this, they are worried about losing work. They're happy to be with their loved ones at home. However, if you tell me less than 6 months, I can't take that off. If you tell me a week, I'll take it off. I don't care about work. So that's why it's really important. Now, for an AML patient, what makes sense? So it is appropriate when ongoing treatment and supportive transfusions no longer provide benefit. Now, a lot of AML patients still are able to get to the clinic to get blood and platelets and their antibiotics. When they're no longer physically able to get there, that is when the focus of 100% hospice should come into play. And remember, hospice pays for the therapies related to comfort. They can't pay and they can't afford to pay for antibiotics, antifungals, and transfusions. So that's why for AML patients, they're kind of in this in-between mode with palliative care for a long time before they're really eligible for hospice. So again, ongoing collaboration is getting on the same page, really communicating well with you all about what's being offered and along every step of along the way. You know, when Glenn mentions these medications, even the newer ones for AML and the clinical trials and the stem cell transplant, with palliative care, we need to know the risks and the benefits and the burdens, because patients need to know these things so they can make really good decisions. And prognosis without these things. So our conclusions are that AML is really a challenging illness, especially in the elderly, and I think especially for everyone. More options, amazingly, are available right now. There's targeted therapies to really improve quality of life. They have fewer toxicities. Stem cell transplant is still a curative option well into people who are aging and older. And it's really important to have early palliative care consultation and be part of this long-term conversation and collaboration. So, thank you.
This working?
Right.
Can you guys hear me?
I think we have time for maybe just one question. We went a little bit over time. Anything, Alex?
Yeah, we actually had a couple on the chat. I'll just kind of go with the top one. If a patient were to ask someone how azacitidine and venetoclax works against their cancer in kind of simple terms, how would you explain that to the patient?
That's a really good question. I think the combination, they're synergistic drugs that work together to, specifically target the bad portions of their, leukemia stem cells. So I think it's just more of a targeted kind of less toxic treatment, which I think is probably the more important part of that question is, what am I looking forward to when we start a treatment like this compared to more intensive treatment? And this is a very active treatment for acute myeloid leukemia with less toxicity in general.
Thanks, guys. That was really awesome.
Thank you.